and welcome everyone to the 5th Align with ALYN webinar. We have with us Joanne Bly, American Friends of ALYN Hospital Board President, and I leave the floor to Joanne. So go ahead, Joanne.
Thanks so much, Mayan. I appreciate it, and I'm pleased to be here. I'm pleased to welcome all of you to the 5th in our continuing Align with ALYN series, where we host distinguished speakers to provide updates on all the initiatives at ALYN Hospital, funded in part by you, our donors. If you missed the previous Align with ALYN series and you want to catch up, they are available for viewing from the alynus.org webpage or on YouTube at ALYN Hospital Friends. This seminar will be posted there as well. As those of you who have been to previous Zoom sessions know, the American Friends of ALYN model is our support, their success. You can see it above my head. So again, in the spirit of showing what our support has accomplished at ALYN Hospital, I am thrilled to introduce Dr. Simon-Henri Schless, a physical therapist with over 12 years of experience in pediatric rehabilitation. Now, please bear with me as I try to pronounce the names of the universities that Simon has attended. Simon earned a doctorate in biomedical sciences from the Faculty of Kinesiology and Rehabilitation Sciences at the Katholieke Universiteit Leuven in Belgium. That's the best I can do. Currently, he is a research fellow in the sensorimotor systems neuroscience group at the University of Jyväskylä in Finland. How did I do? Since January 2019, Simon has been managing the clinical motion analysis and biofeedback laboratory at ALYN Hospital in Jerusalem. In addition, he is a principal investor at ALYN Park, the Helmsley Pediatric and Adolescent Rehabilitation Research Center. His research focuses on movement biomechanics and neuromuscular physiology. 3 years ago, I visited Simon's lab at ALYN, and I was extremely impressed, and I mean that sincerely. I was blown away. I hope that through the miracle of Zoom, you will be able to feel like you are there too. Please help me welcome Dr. Simon-Henri Schless. Over to you.
Thank you very much, Joanne, for the introduction. You did very well with the pronunciations of the different universities. Can you confirm that you see my presentation? Yep.
Yes, I do.
Great. Okay, so I'll begin. Thank you all for coming to listen this evening. I plan to give a roughly around a 20-minute presentation on the topic of movement analysis in the pediatric population, from research to clinical practice. If you're already a bit nervous, the research part is kept to a minimum, and it will be mostly stories from the clinical practice, which I hope will inspire you to appreciate some of the work that we're doing in ALYN over the recent years. I'll also take this moment at the beginning to acknowledge, in particular, the Irving Montag family, Irving Montag and his family, and the Clarice and Burl Osborne for their donations that made the purchase of the motion analysis laboratory possible, as well as the Helmsley Charitable Trust, which made the various research we're doing, which again goes to helping us improve our clinical practice. So just an overview of what I'm going to discuss today. The first is a very brief introduction of what a motion analysis laboratory is for those who don't know. Then, as I mentioned before, I will discuss some stories from the field, so to speak, the clinical service that we provide for gait analyses, and how this led to changes in treatment planning, as well as some nice stories of patients who underwent biofeedback training, and a very small word about research at the end. I have a slide about who I am, but Joanne did such a fantastic job that I will keep it to a minimum, just to say that I was born in Manchester in the UK. My first degree was in physiotherapy. I was a student at ALYN and then volunteered from 2010 to 2014, eventually working as a physiotherapist. At which stage I then went to do a PhD in biomedical science in Belgium. In 2019, I came back to run the motion analysis laboratory. And more recently, I also became one of the principal investigators at the Helmsley Pediatric and Adolescent Rehabilitation Center, in addition to my work as a research fellow at the University of Jyväskylä in Finland. Okay, so on to the main topic of this evening. What is motion analysis? So motion analysis is facilitated by the acquisition of objective data that describes a subject's movement. So this is a mouthful. A simple way to say this is motion capture. This is what's used in all the big Hollywood films nowadays and in all the computer games that enable an actor or someone to walk in a space, and we can convert that movement onto a computer to data, to numbers, so that we can do something with it. In the context of what we do in ALYN, we're concerned with the biomechanical analysis. So we want to know what's happening in the joints when a patient is walking. And in addition to that, what's happening in the muscles? How are the muscles responding to the motion during walking? So how do we do this? So we use a system called an optical motion tracking system, whereby we stick these reflective markers. Maybe you've seen in magazines of actors, like I mentioned before, wearing these suits with these same markers. We put them on very specific landmarks on the body of the patients. And then what we can do is we can create a model of the skeleton of the patient based on the size of their pelvis, the length of their legs, the width of their knees and ankles, so on and so forth. What that enables us to do is then create 3D models like this. Here you can see a patient is moving their right legs backwards and forwards from side to side. And what we can do is we can then convert that information into graphs of how much the leg is moving in each of the different directions. And then what does that mean clinically? Well, if we're looking at a task such as walking, we can look at what should be happening at that joint during walking, which in the graphs here you can see appears in gray. And then we can see what the patient is doing, which is what appears in green. So it gives us a way to objectively understand how the patient is walking and how much it differs from what we expect to see. In addition to that, we also use something called force plates, which measure the force that the patient applies when they're walking on the treadmill. That's denoted by the red line you can see here. And basically, when we combine the previous information with the force data, we can understand how much force is going through the different joints, how much force is moving through the knee, the hip, the ankle. And this is directly related to how much energy we need to use in order to walk in an optimal way. The optimal walking, we should use as little energy as possible. And what we find in a lot of the children that we see in ALYN is that due to the various neurological or orthopedic impairments that they may have, their walking costs a lot in terms of energy. And one of the things that we want to do is to reduce that energy cost so that they can walk for a longer period of time, and hopefully in a way that's closer to what we would expect to see in terms of typical walking. The other piece of technology that we use is what we call surface electromyography. These are little sensors that in the pictures you can see are the little black boxes. Excuse me. Here, these little black boxes, and they measure the activity of the different muscles. So here you can see a patient's doing a squat, and you can see the different activations of the different muscles during that squat. So this tells us something about the neurological component, the connections from the brains through the spinal cord to the muscles. The other thing that I think is really unique that we have in our lab is an ultrasound system. Now, we use an ultrasound because it gives us an additional ability to look inside the body of the patient, for example, at the quality of the muscle. So here's a nice example. You can see that during a stretch of the ankle, we can see how much the muscle and tendon is moving in response to this stretch. And this can help us to further optimize the different treatment interventions that we do in ALYN. And one of the things we're working on at the moment is here you can see, hopefully the video is running smoothly, a patient walking, a healthy girl walking on the treadmill. And at the same time, we can measure the amount of movement of the muscles and tendons while she's walking using the ultrasound, and combine that with all the information that I mentioned before, the electrical activity in the muscle, the forces going through the knee and the ankle, to get a much more complete biomechanical picture of how this patient is walking. This is what the lab looks like. We have a 180-degree screen, so it's a very immersive environment when the patient is walking. The treadmill itself, you can see there's two different belts, so they can move at different speeds, again, depending on the aim of the assessment. The treadmill also changes in inclination, it inclines and declines, it moves from side to side, and we can also evoke what are called perturbations. So the belt will all of a sudden stop or change direction to create to cause the patient to fall. Of course, the patient walks with a harness here, so they won't actually fall, but it can mimic environments in the real life where they can fall or adapt and improve their balance in a controlled way. One of the other components we have is a virtual reality system, but also an augmented reality. That means we have a projector that projects a continuation of the screen onto this black box and onto the treadmill. And we have certain activations where the patient maybe need to step on the targets or avoid the targets whilst they're walking on the treadmill. So when we put everything together, we have something that appears in the video on the left. Here you can see a patient walking, and in this case, they can see themselves walking live through this 3D model on the screen. And then this is the type of information we get on the right. It's the raw data. We can also do a full body analysis, including the head, neck, and shoulders, again, depending on the clinical question. One of the things we know about the motion analysis laboratory for the use of in clinical practice is that it can improve the clinical decision making, because if we take the example of myself, an orthopedic surgeon, a physiotherapist, and the parent of a child looking at that child walking in the corridor, all of us could see different things. And it's very hard to understand objectively what's actually happening. Now, this system, a motion analysis system, provides us with quantitative and objective data to say this is exactly what is happening when they're walking, to a very high level of accuracy and precision, to overcome the optical illusions of sometimes how much the knee is twisting or how much the knee is bent. And what we see here on this slide is that there are many articles now that show that motion analysis change clinical decision making in up to 60, 70, 80% of cases in various different pathologies. But one of the key things that isn't always addressed, but we found to be incredibly important in ALYN as a rehabilitation center, is the integration of the lab into a multidisciplinary team. What do I mean by multidisciplinary team? I mean the combination of all the different professions that you see working in ALYN. So if we go by the, what we call in English, at least in British English, allied health professionals, the physical therapists, occupational therapists, speech therapists, an orthotist, the person who makes the orthotics or the splints. And then, of course, you have the medical doctors, the rehabilitation specialists, the orthopedic consultant or surgeons, neurologists, and oncologists. What does that mean? Well, I'll answer that in a moment. Beforehand, I'll say that in terms of pathologies, we see a wide range of pathologies in our lab. It can be something of a neurological base from birth, such as cerebral palsy. It could be something of a genetic nature, such as hereditary spastic paraparesis, or it could be a traumatic injury that occurred later in life, such as a traumatic or an acquired brain injury, or incomplete spinal cord injuries, as well as peripheral neuropathies, such as Guillain-Barré, Charcot-Marie-Tooth, basically a wide range of pathologies. So what, as I was mentioning before about the multidisciplinary team, what's so unique about that? It means that when we have our twice weekly meetings, which are now since COVID and have continued afterwards, in person, as you can see in the picture, but also via Zoom, as you can see on the screen. We have our internal team of specialists, so the surgeons, orthopedic surgeons, neurologists, rehabilitation physicians, physiotherapists, and orthotists, together with the external referral, so it could be the referring orthopedic doctor or neurologist or the treating physiotherapist, to discuss the case and try to come to the best treatment plan for that patient. Now, this is unique in my experience in ALYN, because in a lot of other places, excuse me, in a lot of other places, what happens is you analyze the data, one or two people from the team, they write a report and they send it to the family and say, okay, take it back to wherever you want. What we try to do here is create a more holistic approach where we take as much information as we possibly can, combined with our own clinical expertise and the information that we get from the motion analysis laboratory to provide the best possible care for the patient. In order to do that, we always insist that we have a referral question. So we're not just doing an analysis, but we want to know what will be the influence of this particular surgical technique to improve the walking function of this patient, for example. And as I mentioned before, to make a clinical management plan moving forward, not just today, but what we expect to happen in 1 year's time, 2 years' time, and 5 years' time, always thinking forward, not just from the point of view of the clinical team, but also from the point of view of the patient and the family, taking their aims and ambitions into our clinical decision-making as much as possible. So we'll move on to the case studies already. Here we can see a girl with typical developments. That means there is no known underlying pathology. She's 11 years old and she arrived to the lab with a referral from a doctor from another hospital called Hadassah Ein Kerem. This girl has a problem where the bones between the knee and the hips are twisted inwards. And you can see that as a consequence, when she's walking, her knees are twisting in and there's a large gap between her feet. Now, the surgeon referred this patient to us and said, I have in mind to twist the bones outwards. This is the appropriate surgery to do. I want to know, though, how much I should do it. So what the analysis told us here, you can see here what we call the rotation of the hip, the left leg and the right leg. And what was happening is when she was walking before the surgery, that's what you see in green. You can see it's above the gray line. That means she's walking with her hips twisted inwards. And we can also see that it's roughly around 20 degrees of inward rotation. So this told the orthopedic surgeon, in addition to his x-rays that he did in his clinical examination, dynamically during walking, this is the amount of rotation that she needs to undergo in order to turn her hips back to the appropriate level. And as you can see in blue, this is the analysis that was performed 4 months after the surgery. You can see it's a lot closer to the typical band in gray. And here's a video where you can see it's a lot better than the previous video. In terms of the walking pattern, the gap between her feet is a lot better. It's important to keep in mind that 4 months is a relatively short time in such an invasive surgery, but you can already see the improvement just in 4 months. We're moving on to the next case study. It is a boy of almost 9 years of age with cerebral palsy, with involvement of the right side of his body. The right side is impaired, the left side less so. And he was referred to us by a neurologist outside of ALYN for an evaluation before he undergoes what we call a botulinum injection. So botulinum is a toxin that basically reduces the overactivity of the muscle in order to allow the muscle to function better during walking. So here we can see a video of how he's walking. You can see in the right leg, the knee is always a little bent. If you look really carefully, you can see his right heel is always off the floor compared to the left leg. Now, what we did here that was quite unique is we performed ultrasound of the muscles, of the calf muscles, the muscles of the back of his leg between the knee and the heel. And what we can see, this is the knee roughly over here, and at the end would be the ankle over here. Now, if we look at his left leg to begin with, this is the muscle, the gastrocnemius muscle. Those who are avid cyclists will probably know of the gastrocnemius muscle. And this is how it should look. It's a nice, healthy looking muscle. If we compare it to the muscle on the right leg, which is on the same scale, you can see that the muscle on the right leg finishes a lot earlier in terms of how long it moves along the leg compared to the left leg, which basically means this muscle has undergone a lot of changes. It's not what we would call a healthy muscle. It also appears a lot whiter compared to the other muscle. Basically, what this tells us is that botulinum injection is not going to be effective in this case. It's not going to lead to an improvement. So this is something that we realized in the discussion, and we sent it back to the referring neurologist, who then changed her treatment based on this finding here. Now, in itself, that maybe doesn't seem so big, but if you take into consideration, it's an intervention, it's painful, it requires rehabilitation afterwards, which is, for the patient himself and the family, these are all very meaningful things. So if we can avoid unnecessary interventions, of course, this is a huge bonus for us, especially when it won't necessarily help the patient. Moving on to the next case study, it was a similar situation, but not with cerebral palsy. It's a girl with a peripheral neuropathy, a disease called Charcot-Marie-Tooth, which basically leads to weakness of certain lower limb muscles. She was referred to us with a question of she's going to undergo a surgery to lengthen the muscles at the back of her leg in order so that when she walks, she won't be walking on her toes. As you can see in the video, her heels, it's like a tiptoe walking. She's always walking on her toes. Now, in the discussion, I didn't include it here, but in our discussion, we noticed in the ultrasound also changes to these muscles. So what we decided together as a team is that maybe it's better to try something called serial casting, which is when we basically use a plaster of Paris cast, like similar to, a cast that's used after a broken bone, where you move the ankle into a stretched position and you leave the cast on for a week, 2 weeks, 3 weeks, every week potentially moving the ankle to further stretch and then recasting. And what we saw, this is 2 months after the cast was removed, an amazing improvement in how she was walking. You can see here, her heels are on the floor, her feet are slightly less pointed outwards. So basically we said, okay, maybe surgery isn't necessary. So what I included here is pictures showing here you can see her feet really pointing outwards and her knees bent. Here in the middle picture is 2 months afterwards, and the picture at the end is 5 months afterwards. And you can see this gradual improvement in the position of her feet and her knees in the time since the serial casting. So what did we learn from this? The conservative approach of serial casting, which was not initially proposed. Initially, she was planned to have a surgery, led to such an improvement that I can say that this 5 month analysis post is over 2 years ago, and she's still not undergone surgery. So this for us and for the patient is a huge thing that the lab led us to change the clinical decision to such an extent. And the last case here that I'm going to show is an interesting one. It's basically children with cerebral palsy often undergo interventions to treat what we call spasticity, where basically they open up the spinal cord. It sounds very aggressive, I know, and they cut certain rootlets that are causing this spasticity. Now, the problem with this surgery is when done incorrectly, it can lead to a deterioration in function. And that's what happened here with this girl who we advised against it and went elsewhere and did the surgery, and 2 years later was functioning a lot worse. Now, what happened here is we saw a patient at the age of 5 years old, as you can see here, walking on his toes. And what we did is, based on the analysis, we went, myself and the neurologist, to the operating theatre. If you're squeamish, maybe now to look away. Here you can see live the spinal cord open on the bed. You can see the neurosurgeon doing the stimulations, which is part of the operation procedure. And then basically myself and the neurologist gave feedback to the neurosurgeon about whether this was a rootlet that should be cut or not. Now, this is really innovative that I'm not aware of anywhere else, at least in Israel, potentially around the world, that use such an integration between the clinical lab and the operating theatre. And then here is the same patient walking around a year after the surgery, where you can see his heels are a lot more on the floor, basically confirming that the information from the analysis led to such an improvement in patient-specific planning, knowing exactly which spinal rootlets the neurosurgeon should cut during the operation. The last thing I'm going to discuss now is biofeedback training in the few minutes that I have left. Here you can see a nice example of how we can use biofeedback training. Here you can see the robot mimicking exactly what the not patient in this case is doing on the treadmill. I'll skip this slide, it's less relevant. I'll go straight to an interesting case. Here is a girl who had osteosarcoma, so it's basically cancer of the pelvis. Here you can see where they removed part of her pelvis and used her lower limb, the bone from her fibula bone, as a replacement for her pelvis. Now, what happened is over the long term, when she was walking, you can see this lean to the left. She's walking with her left shoulder leaning over her left. And what we do here is training sessions. She can see on the screen how she's walking, and she can use that feedback to try and correct her walking pattern. Now, what we saw after the first session is there was no improvement. But what we saw amazingly in the fourth session here is pre-training, very similar to the first session. Then during the training, where she has the feedback on the screen in front of her, we can see all of a sudden a much more symmetrical walking pattern with both arms less leaning to the left. And then immediately following the training, a carryover from what she achieved in that session. So this is an example of how biofeedback training enabled her, despite this invasive surgery, this big surgery, to improve her walking pattern that we weren't able to achieve in the conventional physiotherapy sessions. And here we can see another girl that had a similar situation where she had a road traffic accident resulting in lots of fractures of her lower leg. Here you can see in the video on the left, the lean she has to the right, and then following 12 sessions of biofeedback, a much more symmetrical walking pattern. Moving on to the second to last case here, I think. We can see a girl after an excision of a brain tumor. Excuse me, here we go. You see in the video on the right, she's walking with her knee bent all the time. And again, she performed this biofeedback training. Here she did 24 sessions that led to a big improvement in her ability to straighten her knee whilst walking, leading to an improvement in symmetry and a reduction in energy expenditure while she's walking. The case here, you can see the patient with cerebral palsy was suffering from a lot of falls due to poor balance. You can see here he's using his hands. His base of support is very wide. And after 12 sessions of training, you can see how his feet are a lot closer together. He's a lot more stable. Here you can see a bit of the feedback on the screen of what he has to do. He has to keep his feet and step on the platforms as he sees in front of him. Here is just to show an example of what it looks like to the patient. So here he's walking. He can see this 3D robot on the screen. In this case, he needs to walk in and move his hip as far backwards as possible into the green zone. So again, it's a fun environment. There's lots of colors. He gets a score every time he does it right. And it's repetitive. He can work over and over again, not just for 5 minutes, but half an hour even, to try to make this a new automatic way of walking. And as you can see in the video on the left to the right, the improvement he achieved after a long period of training, sorry. And here is just some nice videos to show some other concepts of training. Here on the left is a patient with an amputee working on symmetry and weight bearing while standing with his new prosthesis. And here the patient on the right working with dynamic balance. You can see the treadmill is moving left to right, up and down all the time while he has to try and walk and maintain his balance. So those are the examples I wanted to show. I'll just mention briefly about the ALYN Park, the Helmsley Pediatric and Adolescent Rehabilitation Research Center, which consists of 4 main domains, one of them being the area that I work in. And just to show that we have lots of ongoing research, both in Israel and internationally with colleagues in the Netherlands, in Finland, in Italy, with all the research aimed at improving our clinical practice, similar to all the examples I showed before, whether it's orthopedic or neurological surgery, whether it's biofeedback training, or with the aim of improving the care for our patients. So I just wanted to say thank you to all my colleagues. Again, to the Irving Montag and family and the Clarice and Burl Osborne for the donations that made purchasing the lab possible. But then I think also most importantly to the Friends of ALYN, again, for making for your support, making all of our work possible. So thank you very much. I hope you found this presentation to be enjoyable.
Thanks very much. I found it fascinating and even better than when I was with you in Israel. So thanks so much, Simon. We're waiting for people to ask questions. I have a couple of questions, so I'll start this while people slowly type. Do you take patients from outside of Israel, or do they have to be in Israel to come for evaluation?
We can also see patients from outside of Israel. Of course, it depends, if they come from outside of Israel and they're not being an Israeli citizen, then the way the system works without the insurance or with again, so that's the main difference. But of course, we see patients that want to come from the UK, from the States as well, that come to us for analyses and also for this holistic approach of this multidisciplinary team to try and define an appropriate treatment plan.
And just a follow-up question, you show everyone they're all ambulatory. Do you do a motion lab analysis on children in wheelchairs? I mean, to see how their arms are moving. You didn't show any examples of that.
Yeah, indeed. We do assessments for individuals that are in wheelchairs where we can help them go onto the treadmill, and it can be with a focus on things like trunk control. So we put the markers on their shoulders, and then, for example, they have to control a car moving between 3 lanes. And then the whole aim of that is in sitting, they can work using their trunk or even the markers on their head, and it can be head control, forwards to go faster, backwards to slow down. So again, I didn't show any of those examples, but you're right, we also do that as well.
Oh, thank you. We have a question here from Erica. What's the youngest patient?
The youngest patient, usually around 4 years of age. Any younger than that, there's a bit of a difficulty with cooperation because, of course, sticking on all these different markers. So I say 4 is probably the youngest. 3.5 in certain cases where the neurosurgeon or the neurologist really felt this was the optimal time to do the intervention. So we tried our best to provide that information.
Okay, thank you. And then how many, this is from Pamela, how many patients do you see in a month or year, and how long is the waiting period to be seen?
Okay, so for what we call the gait analysis, we have, I think it's 16 assessments per month, which doesn't sound like the maximum, but it's actually quite a lot because each assessment takes 2 hours with an additional 5 to 7 hours of analyzing the data and then having these meetings with the multidisciplinary team. So it's around 16 assessments per month, and the waiting time varies, but it's usually around 2 weeks to a month, depending on the certain times in the year when a lot of patients, for example, school holidays, where if they need to have a surgery, they save it for the summer. So in the months leading to the summer, there may be slightly longer, but it's usually around 2 weeks on average.
Okay, and also from Erica, does age impact the benefit of this therapy?
Absolutely, it's a very good question. When it comes to, if it's something like balance, younger children, as long as they're engaged in the activity, it doesn't matter so much, because if they enjoy it and balance is something they can work, we can do the perturbations. So age isn't a factor. But when it comes to improving walking patterns, there's a concept called motor learning, this repetitive activity to change something that's automatic. Motivation plays a big role. And of course, someone at the age of 12 who is aware of how they're walking, maybe aesthetically, that it looks with, walking with a limp, they benefit a lot more than someone who is 6, 7, or 8 years of age.
Okay, thank you. And do you have a favorite story of working with the child?
Yes. Should I carry on with my story, or should I go on to the other questions? I'll give a nice little story. I think one of the nicest things in my position is not just meeting all these different children and families from all different backgrounds as well, but is this ability to be involved in the process of going down the direction that maybe a surgery or something invasive is what's scheduled. And then based on analyzing the data and finding, I call it like a bit of a Sherlock Holmes, not just because I'm British originally, but the process of deduction, ruling out everything that is not and leaving what it can be in front of us, and then seeing based on those impairments or those problems, what the optimal solution is. And I think in those cases where we can avoid doing a surgery and we can propose something less invasive, but still have very good outputs, like one of the cases I showed, for me, these are always wonderful stories, because it's the best of both worlds. You've saved them going through something really potentially traumatic. Yeah, it's always nice to see that, especially for the families.
Okay, and do you do training for other facilities in other countries?
Yes, so we have a lot of contact with different people that use similar systems. I recently, a few months ago, gave a webinar on how we were successful in clinically integrating this system at ALYN, which in a lot of places that use a similar system is mostly for research and also in adults. And one of the things we achieve is to make it a clinical tool for use in children. So I'm in contact occasionally. The company that supplies a lot of the equipment contacts me every few months saying that there's someone from this country that would like to consult with you about how we do this, or if there's any tips. So we have that all the time. And there's always, every month, there's visitors coming from within Israel as well to see how we're doing it and how they can apply it in their centers.
All right. How long after your last therapy session do you have follow-ups with the patients?
So it depends. It's also a really good question. It depends on the pathology. One of the cases I showed of the girl with the x-ray where her pelvis was replaced with a bone from her leg, we did a follow-up after 3 months where we did, I think, 3 more training sessions. And then 6 months after that, or 6 months after that, she came for a follow-up analysis where we saw that there was a bit of a regression compared to her maximum gains, but it was way better than where she was before she started. In other pathologies, sometimes we do follow-ups after 1 month to give a booster. Sometimes if the results are really good, we'll wait a year. So again, it depends on the pathology.
Is there any way to take these biofeedback sessions and give it to people as an app at home in some way? You know, because you can play with all those games and it knows your motions in games. So I'm wondering if that's a possibility.
It's an ongoing research. We have in the research center and in ALYN, we have what's called ALYNnovation, which is to do with startups and supporting startups in projects that can benefit the children and the patients in ALYN. So one of the ongoing things we're looking at is how to develop a protocol in the lab and then transfer that to the information to very small sensors that the patient can then train with at home and get feedback, say, from a beep in the ear if they did the motion correctly or not. As a research to begin with, of course, to test the validity, but indeed the aim long-term is, as the tool always is not to correct, is to educate in the lab so that they could take it home and apply that in the real world. And we're always looking for opportunities to reinforce that.
Oh, that sounds good. And what's your favorite part of the job?
Wow. Helping people, it always gives you a good feeling. Maybe it's selfish, I don't know. Yeah, that's always great. I'm also, I don't know if it came across in the presentation, but a bit of a nerd for scientific things, biomechanics and muscle related things. And some of the things we have ongoing at the moment are some really innovative, unique techniques where we're only one of a few centers around the world that are doing this to basically map the development of motor control from the brain to the legs. And the things we're finding out in this are really, really potential game changers for improving the care of our patients. So that for me is a really big part of my job. I suppose that the short answer is finding new ways to improve care for the patients and not just going off the same things that we always do, but trying to think out of the box to find new avenues to improve the function and health of the patients we see in ALYN.
Super. I don't see any questions on the board, but I have one more. Oh, see, when I say that, people always chime in. You showed one example of where you were in the operating room, which was fascinating. Do you do that a lot, or was that a one-off?
So maybe this was a story that I didn't take the opportunity to mention before, and I see that Brenda's in the audience. And if Brenda found out that I didn't tell this story, it'd kill me. So I think I'll very briefly give this little anecdote. What happened once that led to this new approach where we joined the surgery. One day I was in the lab. There was no assessment. I can't remember. I was maybe analyzing data, and I got a phone call from the neurologist, the resident neurologist at ALYN, panicking. Simon, I'm in the operating theater. We have a patient here on the bed. We're trying to target these muscles that we said clinically with the muscles we need to do whatever we need to do. And we're not able to stimulate them. We're not able to find them. Are you absolutely certain in your lab that that these muscles were the problematic muscles? I said, give me 10 minutes, I'll call you back. I went over all the raw data. Again, I'm panicking. Maybe I made a mistake. Maybe I sent a child to, I suggested that a child should go in. And then I found, hang on, everything was as I said. So I called her back and I said, all this information is as we said. We saw these muscles were the problematic. She said, okay, thank you. And that was that. Later in the evening, she called me up, said, I hope you're still not in the operating theater. She said, no, I'm home now. But I had an idea. I think we need to integrate the information of the EMG that you get in the lab and join in the operating theater. And when they're doing what they do and they stimulate the muscles, as I showed in that video, we need to be the ones there telling them, the surgeons, because what we found out, the surgeons, as much as they do a wonderful job, they work according to a surgical protocol, which doesn't always match what you see in clinical practice. And sometimes it can even be very far away. And what we've started doing is we said, well, let's bring in our clinical impairments and apply that to the surgical protocol. And since we started doing that, we actually started to see that this led to a much more patient-specific treatment plan. And again, we didn't study this in a way that we can say that it's 100% better, but the clinical feeling is for sure that this led to better outcomes for the patients. And that's basically what led to this situation where I think it's around every 2-3 months, because it's not such a common surgery, this big surgery, the neurologist and I join in the operating theatre for the purpose of optimizing which things need to be done there.
Okay, that's terrific. When did you decide this was what you wanted to do? Were you always interested in medicine and then became your focus?
No, I think as a physical therapist, the age of 18 in Manchester, I wanted to be the physical therapist for Manchester United, obviously. I mean, it's the natural approach. And then what happened was I needed to do a final internship in the field of pediatric rehabilitation. And I hadn't done one. And a friend of mine just came back from ALYN. He was a year ahead of me. And he said to me, listen, next year, you need to go to this hospital in Jerusalem called ALYN. They have a pool with a fantastic view. And if you're lucky, they'll let you go swimming there at the end of the day. That sounds great. I'll do that. And then I'll come back and I'll be the new physical therapist for Manchester United. And then that's basically what happened. Half that's what happened. I went to ALYN and then I basically stayed. I came home for 2 weeks to get my diploma. And then I went back again. I volunteered over the summer and then I started working as a physiotherapist. And aside from those 5 years when I did my PhD, again, I came back to ALYN and now almost 4 years back again in this new position. So what triggered this change? I think working with kids was great. It was an eye-opener and very rewarding. And I think in ALYN particularly, it's a very family-run place. You know everyone. It's a great place to work. The environment is very nice. I think that's what did it.
Oh, yes. Well, any of us on this call who've been to ALYN can understand that. There's something that comes over me when I enter that building. That's a phenomenal feeling. So that I can absolutely understand. And this last question here, watch, I'll say last and someone else will type. How have you gone about the tech and data crunching? Is that from ALYN Innovation?
Great question. Some of it comes from ALYN Innovation, but some of it, most of it, to be honest, is one of my jobs basically, based on my PhD and the sort of advanced things that I had to do there. I basically look in the literature and I try and think out of the box, and I use the support if I need it. But I basically try to find ways to, as you call, crunch the data, to take all these 200, 300 parameters and optimize them into which are the most important ones for the different clinical questions. So it took a while, but I didn't have time to go into it, but we have all sorts of measures now that a single value can tell you if a particular patient with a particular pathology is likely to have a positive response from a surgery or not. So it's a combination of things, but part of it comes from my academic background.
Okay, well, it's just about 1 o'clock when we're supposed to end. So I want to thank you very much, Simon. I thought it was great. As I mentioned, we'll be distributing video of this presentation to all of you tomorrow. Mayan's nodding her head, which means that I'm telling the truth here. And posting on our YouTube channel, where you will also have the opportunity, just a little plug here, to donate to ALYN if you feel so inclined to continue this marvelous work. And please look forward to our next series in late October, early November. And you can always forward this video to your friends and donors, families and neighbors, and invite them to the next presentation to help us spread the word. And remember, it is our support, their success. Anything you want to say, Mayan?
Just thank you, Simon, for a wonderful presentation. And thank you, everyone who's been tuning in. We appreciate that you are interested and engaged with us, and feel free to ask any questions anytime. So thank you.
Have a great day. Have a nice evening, Simon. I'll see you in a couple of months. I'll be there.
Looking forward to it. Thank you for the invitation.
Thank you. Bye-bye.
Bye.